Good evening, all. Welcome to this new session. We will try to see some important OSCEs for the exam going students. So, whenever you see a case, try to save it, make a slide on it, and then share it. These are the 4 S you can remember so that you can help your colleagues and even students. Coming to the first case. So, this is a young male with severe vomitings and chest pain after barium swallow. So, here you can clearly see there is a faint barium. You can see faint barium noted in the esophagus, and also there is a leak of the barium into the thorax and also into the mediastinum, and also you can see there is extensive surgical emphysema in the soft tissues of the left lateral chest wall. And also here, because of sudden history of vomitings and chest pain following barium swallow, this is definitely a rupture of the esophagus and spillage of the barium into the mediastinum and even the thorax. So what is the diagnosis? This is nothing but called as Boerhaave syndrome. So Boerhaave syndrome refers to an esophageal rupture secondary to forceful vomiting and retching. What is the triad which is seen in the diagnosis? It is Mackler's triad. There is a triad of vomiting, chest pain and subcutaneous emphysema. As we have already seen, this is the subcutaneous emphysema. And also mention the pathology which causes these imaging findings. It is 90% of tears occur along the left posterolateral wall of the distal esophagus, that is 3 to 6 centimeters above the esophageal hiatus of diaphragm. So remember Boerhaave syndrome and Mackler's triad. And what is the common rent, that is left posterolateral wall of the distal esophagus. Next, 44-year female with recurrent history of abdominal pain and weight loss. So you can pause the slide and see the questions. So here you can see what is the diagnosis. This is nothing but a median arcuate ligament syndrome. You can see this is a soft tissue like rin which is causing compression over the proximal celiac artery and which forms a typical J-shaped indentation over the proximal celiac artery. This is nothing but the median arcuate ligament which joins the both crusts of diaphragm. What is the typical Doppler duplex ultrasound findings is increased PSV is greater than 200 centimeters per second in the celiac artery, and end diastolic velocity greater than 55 centimeters per second, and PSV's ratio of celiac trunk to aorta is nothing but more than 3:1. These are the typical Doppler ultrasound findings which can be seen in median arcuate ligament syndrome. And imaging in which phase of respiration will accentuate this entity, especially expiration or end expiration will accentuate this entity. So remember, this is nothing but a median arcuate ligament which is compression over the celiac artery and forming a J-shaped indentation leading to the typical symptoms. Next, 26-year-old with history of seizures, acute left flank pain and hypotension. Here you can see there are heterogeneously enhancing lesions noted in the kidney with few fat containing areas. Here also you can see these are the fat containing areas which are seen in bilateral kidneys, and there is a heterogeneously hypodense lesion also noted extending from the kidney into the abdomen and also into the left iliac fossa and also extending along the left psoas muscle. So what is the diagnosis? These are nothing but you can suspect angiomyolipomas with sudden rupture. So what is this diagnosis? This is called as Wunderlich syndrome, where you can see the angiomyolipomas which can rupture and lead to hemorrhage into the kidney and also in the perinephric spaces. So what is the triad seen in this diagnosis? It is Leng's triad, that is acute flank pain, flank mass and hypovolemic shock. Can malignancy cause this imaging appearance? Yes, renal cell carcinoma can be the underlying cause which can cause Wunderlich syndrome. Criteria of risk for developing this complication, this is very important. You can see angiomyolipomas greater than 4 centimeters and angiomyolipomas associated with aneurysms larger than 5 mm are at risk for rupture and hemorrhage and lead to Wunderlich syndrome. So whenever in a case of tuberous sclerosis, when you have bilateral angiomyolipomas, if the patient presents with sudden flank pain, mass and hypotension, definitely suspect Wunderlich syndrome. Next, you can see this. What is the diagnosis? You can see there is a faint radiopaque lesion noted in the left lower abdomen, also in the left iliac fossa, and also you can see there is a multiple air foci surrounded by hyperdense foci and also in the soft tissue component, especially noted in the left lumbar region. So what is the diagnosis? This is typical case of Gossypiboma. And what specific history we have to ask in the previous history of surgeries is the specific history we have to ask in these type of patients. Which tumor can develop in this type of complication? The rare complication of retained surgical sponge is angiosarcoma. And how to prevent this complication? Typically we have to have the swab count, that is theater swab counts at the start of the procedure and end of the procedure, and both the swab counts should match. So we should have a absolute matching of the both the swab counts before closing the abdomen to prevent this retained foreign bodies or Gossypiboma. Next case, you can see young adult came with complaints of poor appetite, weight gain, recurrent cough, respiratory infections with sputum, and recurrent onset of abdominal pain presented with abdominal distension and vomitings. Here you can see there is the whole of the pancreas is replaced by fat, that is pancreatic lipomatosis, and there are multiple small bowel loops which are dilated, and also few hyperdense foci noted within the abdomen, scattered within the abdomen. So this is nothing but a case of cystic fibrosis, as there is pancreatic lipomatosis. So what is the most probable diagnosis, which is called as distal intestinal obstruction syndrome, also known as mucinous ileus. So this is that hyperdense, sometimes mucinium can be seen, and there is obstruction of the small bowel, and in a case of pancreatic lipomatosis. So this is nothing but obstruction of the distal small bowel by mucofeculent material. And what is the pathology or genetic defect which cause this disease is cystic fibrosis due to a homozygous defect of the CFTR gene located on chromosome 7q31.2. What is the best treatment for this complication? It is nothing but conservative treatment, that is adequate hydration, aperients including water soluble or gastrographin contrast enemas can be tried. Intestinal lavage can be tried in recurrent cases. So the main mode of treatment is nothing but to pass off the mucofeculent materials and relieve the obstruction. So you can see these are radiopaque foci noted in the palatal kidneys, which are filling the bowl of the pelvic system, and also there is a radiopaque density in the left lower ureter. So what is the diagnosis? These are nothing but palatal Staghorn calculi, so or coral calculi. What is the specific history we have to ask? Any intravenous contrast administration previously has to be asked, because intravenous contrast administration or IVP can also produce pooling of contrast in the kidneys and produce this imaging appearance. What is the etiopathogenesis or causating organism? Recurrent urinary tract infection with urease producing bacteria, that is Proteus, Klebsiella, Pseudomonas and Enterobacter are the common etiopathogenesis or causative organisms for this complication. What is the composition of this entity? Typically they are nothing but struvoid calculi in the renal pelvis extending into at least 2 calyces. This is the criteria for Staghorn calculus, and these are nothing but triple phosphate calculus, which gives the classical laminated appearance. What is the triple phosphate? How to you can remember? You can remember the mnemonic as calcium, ammonium, magnesium phosphate, that is CAMP or camphor. So camphor you can remember for Staghorn calculus, and also typically the gross appearance will mimic as ginger. This is nothing but ginger in the kidney. This kind of appearance is nothing but described as ginger in the kidney. Remember camphor and ginger in the kidney for Staghorn calculi. Camphor means calcium, ammonium, magnesium phosphate. So 44-year female came with history of mass per abdomen pain, and ultrasound reveals large solid pelvic mass. You can see there are multiple fibroids. So what is the diagnosis? These are multiple uterine fibroids. What is the classification used? This is FIGO classification. What are the complications? Invasion of adjacent venous channels leads to intravenous leiomyomatosis, malignant degeneration into leiomyosarcoma, which is very important in less than 1.5 to 1%. Sometimes benign metastatizing leiomyomas, torsion and even pyomeyomas. And also like pregnancy, there is red degeneration, calcaneous degeneration, hemorrhagic degeneration, or different types of degeneration can be seen in fibroids. What are the interventional treatment for this pathology? Uterine artery embolization and high intensity focus ultrasound. These are the common interventional procedures for fibroids. Next is last case, 26-year female came with a history of fever, sore throat, dilated sensorium. So what is the diagnosis? This is nothing but acute hemorrhagic encephalomyelitis. Here you can see there are hyperintensities noted in the corpus callosum, in the basal ganglia, and also in the subcortical white matter. And also there are multiple microhemorrhages noted in the above mentioned white matter lesions on GRE. So this is acute hemorrhagic encephalomyelitis or Hurst syndrome. What is the common history? Upper respiratory tract infection prior to the presenting neurological symptoms in 50% of cases. What is the differential diagnosis? Acute disseminating encephalomyelitis. What is the pathognomonic imaging features in this diagnosis? There are multiple cerebral microhemorrhages. You can see multiple cerebral microhemorrhages is the classical pathognomonic feature which helps in differentiating AHEM from ADEM. What are the specific sequences which are used which helps in different diagnosis? GRE or susceptibility weighted imagings like SWR, SWAN can detect cerebral microhemorrhages and helps in differentiating AHEM from ADEM. Thank you all.